and my husband is a 2.5-year survivor of peritoneal mesothelioma. And my question is, what is the rate or possibly the incidence of peritoneal moving to pleural also? His is epithelial at this point and doing well, but I do know some instances where it has also moved to the pleural. And I was just kind of wondering what the incidence was on that.
Dr. Rucktershaw will be happy to take your question.
The easy answer is we don't know. There's no firm data on it. But I think with this disease, the longer people live, the more likely these uncommon events are to happen. So it depends on what the extent of the disease was originally. If the disease was on the underside of the diaphragm, the likelihood that over time it's going to spread through the diaphragm and involve the pleura is pretty high. This is not usually a problem because people don't live long enough to have that occur. But certainly if his disease was further down elsewhere in the peritoneum, not involving the diaphragm, then the chances of that would be quite a bit less.
Thank you. Thank you, Joe. We have another question?
Yes, I'm Blue Wilson. I'm with Prior Steelworker, United Steelworker.
Welcome.
We are finding that a lot of guys are having problems with the colon, having the bags put on. Is there any other issues as far as with liver? We're finding a few of the guys developing some forms of liver cancers. Could this be in any way an asbestos issue?
Dr. Harbert, Dr. Rucktershaw?
Well, we know that...
Mike?
Let me figure out how to use it first.
Often we just speak into it.
Thank you. Thank you. That's why he's the boss. We know that there's twice the risk of getting colon cancer with asbestos exposure, period. Secondly, we know that if you work in a steel mill, you are exposed to benzene, carbon tetrachloride, carbon black, all sorts of what are called pyrolysis products. There was a number of years ago shown a relationship between working in a steel mill and getting prostate cancer. Now, on the question of the liver cancer, of course, there's metastatic disease from the colon that can occur there and other organs. But in terms of asbestos causing a separate, special liver primary cancer, that has not been reported to my knowledge.
Okay. Thank you.
Working in a steel mill, you're working in a pretty dangerous environment just walking in the door.
Thank you.
But there's progress with medicine all the time.
I'm Laurie Kazan-Allen from the International Ban Asbestos Secretariat. A couple of weeks ago, I was at a mesothelioma study day in Manchester, and the doctors talked about the opening of a new chordotomy center. I don't even know if I've said it properly. And I wondered whether the doctors here have any thoughts on using this new procedure for mesothelioma patients.
Dr. Rucktershaw?
Unless that's a British term that I'm unfamiliar with. I'm not. Chordotomy is usually something we do as a pain procedure.
Yeah, that's right. To help people deal with the pain. I mean, it sounds
that's been done here for many years.
Sorry?
It's just part of our pain clinics.
So it's normal.
It's a pretty drastic procedure, and I would say the number of people that come to that is extremely small. I mean, most people we're able to control on either oral or intravenous narcotic analgesics or through hospice. And the number of people we send for neurosurgical pain relief is really fairly small.
Okay, thank you.
But yes, it's a pretty standard procedure.
This will be our last question. Oh, yes, of course.
Hi, I'm Sherry Scarpelli. I'm from Sarnia, and I'm a survivor. My father died in 2004, or not 2004, 2006 of mesothelioma. And my question is to the doctors who are treating the mesothelioma patients here at the Cancer Center. I see in your presentations that you're offering them chemotherapy and radiation therapy. And we know that these are not successful because there is no cure for mesothelioma at this time. So what kind of quality of life are you offering these patients?
Maybe we could focus on palliative care, possibly what you do at the Institute?
No. I think this is a very important question. This has been an argument between Canadian and American oncologists for almost 30 years that I've been involved in this. People are fond of talking about median survival. Well, if you don't do anything, they die in 6 months. median, and if you do something, they die in 8 or 9 months, and is it worth it to do something that only prolongs survival by 2 or 3 months? And I think that's a statistical trick we use to try to get studies done earlier. It's not helpful. I like to think about survival at 1 or 2 years, and to think whether or not what we're doing gives someone a better chance of getting to 1 year or 2 years. And then it's a patient-by-patient, family-by-family decision. If you've got, and I like to think in extremes, if you're in a nursing home, your friend, you can't pee, you can't poop, you can't see, all your friends are either dead or infirm, I mean, any aggressive treatment makes no sense at all. At the other end of the spectrum, if you're 45 and you've got young children and you've got an active family and one of them's getting graduating from university or getting married or whatever else, and you want to be there for that, then picking up that extra year or 2 makes a lot of sense to do that. I think anybody who makes a patient sicker with chemotherapy and radiation really ought to think about what they're doing in the field. I mean, there's going to be some short-term side effects of therapy, but if the patient is doing worse, you stop what you're doing and you do something else, or you go to palliative care, whatever, supportive care, whichever makes sense. But the vast majority of people tolerate chemotherapy fine, but the reason they start doing badly is their cancer starts doing badly. And it's the key. If it's the chemo that's wearing them down bad, you need to change the chemo or change what you're doing for the side effects.
Thank you.
Speaking of side effects, I'd like to address one issue for the tape. Is there are many people that contact ADAO because they have severe pain, they're having difficulty breathing, supplemental oxygen hasn't been presented. So I think for those here in the audience, if you're a doctor or you're a victim, it's really important to know that you have trained experts like this that have a tool bag full of options. So describe your symptoms, make your request. They're not going to fool you, but there are treatments out there for symptoms, and we're coming a long way. So just because you're maybe concerned about getting addicted to pain medicine, which I've heard many times, that's inaccurate. And we promote open discussions with your medical team.
Yeah, there is absolutely not a shred of evidence anywhere about addiction to pain medicine and people who have cancer-related pain. Cancer pain is very different. There are 2 basic kinds of pain we deal with: acute pain, which is tissue damage pain, and then chronic pain, which is sort of the aches and pains we all get as we pass 39, the low back pain being the quintessential one. And what happens is where you get in trouble is people with low back pain, chronic pain, are given narcotic analgesics. That's where you see a problem. People who have cancer have a unique kind of pain. It's chronic acute pain. There's constant, chronic, ongoing tissue destruction with a real reason, and those people don't ever get addicted. I mean, I've been doing lung cancer for close to 30 years now, and I can't say that I've ever seen a patient become addicted to pain medicine as part of that treatment for the supportive care or the active management of the disease.
Thank you. That's excellent. We're going to make an exception. There's a gentleman that traveled here from Belgium. His name is Eric, and he has a question, so I can't say no.
Oh, my God. Yes, good morning. I'm Eric Jonquier. I'm representing ABEVA, the Belgium Victims Group, and I'm a victim myself. I have a question for the doctors here on the panel. I've noticed that nowhere I did see the presence of physical therapy in the team, nor homeopathy, as, of course, not a cure, but as help or maybe new ways. Are any of these ways being explored in the US? And is it possible that this kind of medicine could be added to the team that seem to be set up, in order to surround the patient and to help the family find solutions? I saw that Linda had not put in her list, a physical therapist, and I was wondering if because it's not available, or because we don't think it's important.
Frankly, for a quick answer, is on Alan's team, he only had like intermittent physical therapy, but he's bedbound. It didn't treat his other mesothelioma symptoms, so it wasn't something that's a very excellent point.
Right. Each of our teams have all of our nurses, social workers, the nurse practitioner from the pain team. They're all part of that, and where physical therapy or rehabilitation. We have our own neighboring rehabilitation institute and center down here. So yes, we use it as part of it. It's not something where we would say, okay, we're going to send you for physical therapy as a treatment for the disease or as a treatment for your side effects is when they have specific rehabilitation-related problems or physical therapy-related problems, and obviously it's used fairly frequently. Homeopathy is not particularly popular in the States. I think there are a lot of the things that go along with massage therapy and other forms that are useful adjuncts. We use them. We have lots of support groups for that and lots of availability of it. But if by homeopathy you mean the lower doses of medication and the so-called natural substances, most of that's fraudulent in my view, and so we don't use a whole lot of it.
I would do a disservice to some patients that contact us for alternative medicine, because there are some places, and I know in traditional medicine it's not maybe proven and it's skeptical at times, but for some patients they do seek alternate medicine, and I think keeping an open mind as an advocate is important, just to look at all the options available. But don't defy traditional medicine on a gamble and a bet.